Good evening, everyone. Welcome you all for the IPNA endorsed Webmaster Series 2021, which is an exclusive pediatric tubular disease symposium. We are just left with 2 more sessions of tubular nephrology. The polling session winners will be announced in the subsequent series. And so today we have 2 eminent speakers, Dr. Edwin Fernando and Dr. Sukanya Govindan, and the session will be moderated by Dr. Asim. And she is the head of Department of Pediatric Nephrology at National Institute of Child Health. And her specific area of interest is towards genetics and pediatric nephrology. And she is also a supervisor for the 2nd fellowship training in pediatric nephrology and general pediatrics. And she is a co-investigator of the Dragon study, which is on genetic analysis, primary cystic kidney disease in children. And she is also a co-investigator of SARS study of pediatric severe AKI. Over to Dr. Asim to moderate the session and introduce the speakers.
Thank you, Dr. Calvini. Thank you for the nice intro. And without further delay, we'll just like to welcome all our participants to this 3rd season of the IPNA webinar series. And today we are at the 11th session of our webinar series and hope to have our interesting session today about from our 2 eminent speakers regarding the tubular disorders. So without further delay, I'd like to invite Dr. Sukanya Govindan. Dr. Sukanya Govindan is a senior consultant in the Department of Nephrology at Dr. Mehta's Hospital. Dr. Sukanya is, mashallah, an energetic nephrologist and has gained her ISN fellowship from Great Ormond Street Hospital. And today she is going to talk about very important aspect of the pediatric nephrolithiasis, more important, the genetic causes of pediatric nephrolithiasis. So all about hyperoxaluria. So Dr. Sukanya, the floor is yours and we are ready to listen all about hyperoxaluria from you.
Yeah. Thank you, Dr. Sadaf, and for the kind introduction. And I would like to start by congratulating Dr. Kalaivani for the excellent and sustained focus on various disorders in kidney. And it's really important and very nice that she's taken up the tubular disorders this time. This is at once the most challenging and also the most confusing and also more educative topic. So thank you for giving me this topic. And moving on to to the topic, it's all about primary hyperoxaluria. So in the next few minutes, I'll be speaking on the epidemiology of this rare disease, the etiopathogenesis, what causes such devastating complications, the clinical presentations of the patients, how do you diagnose this disorder, and how do you treat this disorder, which is quite challenging, and also are there any future promising prospects in the treatment of this disease. So this disease is quite old and it's been described for more than almost a century back. It was first described by a French urologist as who looked at oxalate deposits in the post-mortem kidney of infant. So that's how it was first described. More and more we realize that this is an autosomal recessive disease, and although the true prevalence of primary hyperoxaluria varies across populations, it is generally accepted that primary hyperoxaluria, the type 1, which is the most common of these forms, has a prevalence of roughly around 1 to 3 cases per million population. And the incident rate somewhat varies between, we have only data from Europe, it's approximately 1 case per 120,000 live births. And the prevalence is slightly more or multiple times more when consanguineous marriages are common, especially in regions of North Africa and Middle East. And overall, this rare disorder but devastating disorder accounts for 1 to 2% of all pediatric end-stage renal disease children, according to various registries which are available. To go briefly into the etiopathogenesis, it can be put like this. So the starting point is something in the liver, where there are 3 enzymes which deal with pyruvate, glycine, and many of these things. And the decreased activity of these 3 enzymes finally culminates into oxalate overproduction. So these are the 3 enzymes. So this results with more and more oxalate overproduction, which overwhelms the kidney's capacity to excrete it They result in oxalate supersaturation and also deposits in the kidney. With more and more deposits in the kidney, there's going to be parenchymal damage and progressive loss of GFR, resulting in chronic kidney disease and CKD5. With progressive worsening of kidney function, the oxalate overload is only going to worsen because it's neither excreted by the kidneys efficiently now. So there's systemic oxalosis, and this systemic oxalosis spares no organ literally in the body. And you have deposits in the blood vessels, bone, skin, bone marrow, heart, in the central nervous system, and in your eyes. So what causes such devastating complications? Where does it all start? So primary hyperoxaluria, we recognize currently 3 different varieties of primary hyperoxaluria. And this is because 3 different enzymes are behind the 3 types. These 3 enzymes are specific to each organelles. One is in the peroxisome, and one is expressed in the cytosol, and one of the enzyme is expressed in the mitochondria. 2 of these enzymes are specific to liver. However, the GRHPR, which is present in the cytosol, is ubiquitous and is present in all tissues of the body. So the primary problem seems to be the overproduction of oxalate, which results from the increased production of its immediate precursor, which is glyoxylate. So there is a defect in the glyoxylate metabolism. And so there is an accumulation of glyoxylate in the cytosol, which is then acted upon by the LDH, which results in oxalate overproduction. In normal circumstances, glyoxylate is either converted to glycine by the AGT enzyme, which is otherwise the alanine glyoxylate aminotransferase, or it is shunted into a glycolate pathway, which is done by the GRHPR, or the glyoxylate reductase hydroxypyruvate reductase. And there's this third enzyme called the HOGA. Although there is much controversy about the actual substrate of this enzyme and also the actual activity of the enzyme, it has been demonstrated in many patients that the deficiency of these enzymes somehow results in overproduction of oxalate. So what happens basically, and why do these enzymes do not function? The majority of the catalytic activity of the primary enzyme, which is the AGT, which is responsible for primary hyperoxaluria, it exists in the dimeric form. The dimeric form of this enzyme confers its increased catalytic activity. The stability of the enzyme is increased, and it also is important for its localization to the perioxisome, where its main function happens. But in primary hyperoxaluria type 1, there is decreased dimerization, and there is more of this monomeric form. So these monomeric forms are something like intermediates, which are easily proteolyzed and get decayed. So many of the mutations that happens in this AGT enzyme or the AGT gene results in either monomerization. So there is false localization of this enzyme to the mitochondria. So as I said, the dimerization is important for its localization to the perioxisome and also for the stability. So not only with mutations causing monomerization, is not only that the stability of the enzyme is decreased, it's also that the localization of the enzyme goes back to the mitochondria rather than the perioxisome. So all of this would result in decrease in activity of the AGT and increase in glyoxylate being converted into oxalate. So this is the sort of a gist of the etiopathogenesis of this whole disease. The mutations and the underlying problems in the enzymes of PH2 and primary hyperoxaluria 3 are poorly characterized, and hence I'll not be going into them. Going to the clinical presentation. This disease is as complex as it can get in any tubular disorder. So you can have a multitude of presentations in these patients. Quite often we catch them young, and quite often the presentation happens earlier, but there is different ends of the spectrum can happen, and one can easily be misled with the presentations of these patients. Almost 60% of these patients do definitely have some onset of some symptoms before 10 years of age, and majority, almost 83%, before 20 years of age. So there's definitely some suspicion can be raised at first instance of these symptoms. And majority of these symptoms are urological symptoms. It is either in the form of stone passage or hematuria or detection of nephrocalcinosis in an ultrasound. The median age at first symptom onset, which is mostly urological, happens around 5.5 years of age. But the age at diagnosis of this condition as primary hyperoxaluria, or the definitive diagnosis, somewhat delayed, around 15 years of age. There is also that some patients do not present with symptoms even till 30 years or sometimes even older. It's by chance they are detected even asymptomatically or pre-symptomatically. Moving on, but the most difficult and the most challenging part is many of these patients, a significant number of these patients end up being recognized only after kidney damage is irreversible, and almost 30% of them are found out at the end stage kidney disease at CKD5. And very unfortunately, 10% of the patients with primary hyperoxaluria diagnosis have such diagnosis found out only after recurrence in a allograft after kidney transplantation. So they do not have any idea about the basic disease prior to transplantation, and unfortunately they lose their grafts after they have a recurrence in their allograft. There are many registries for this rare disease, which sort of gives us an idea of what is the most common presentation and what is the age groups that are affected. Of importance is this Rare Kidney Stone Consortium, which has roughly around 800 to 900 patients till date, and it sort of includes many, almost all continents in the country, and many countries contribute to this registry. So it's a fairly very heterogeneous record of hyperoxaluria, and also has multiple ethnicities involved. So of this, from this consortium, we know that the PH1, primary hyperoxaluria type 1, remains the predominant diagnosed variety of this condition, and it's almost around 68%. Previous registry data put it at 80%, but it's slowly PH2 and PH3 are being more and more recognized. PH2 is 10% and PH3 almost 11%. So PH3 is the second most common variety, seems like it. And also, even though patients have classical hyperoxaluria with urine measurements and plasma measurements, up to 11% of them need not show any mutations in their genetic analysis. So the data from this registry shows that symptom onset can be even in infancy, and it can vary as much as just a failure to thrive. And although urological symptoms predominate, urological symptoms could be anything from an imaging finding of a nephrocalcinosis or urolithiasis, or having symptoms like hematuria and abdominal pain. And 10% of patients are asymptomatic when they are diagnosed with hyperoxaluria. The age in years at first symptom, predominantly, as I said, the first symptom could have happened anywhere between 5 to 10 years of age, and majority do have their first symptom between 5 to 10 years of age. But there is a gradual tapering, and regardless, first symptoms could happen even in the 6th or the 7th decade of life. So that's what makes this even more challenging at advanced ages. And also the kidney status is age. Very little patients have preserved kidney function, especially with primary hyperoxaluria. Almost ESRD by the 3rd or the 4th decade is the norm in this condition. Patients with PH2 and PH3 might have a variable course, and they might be contributing to the little bit of normal renal function or preserved renal function that you see across the older age groups. But as I keep telling, primary hyperoxaluria is definitely a spectrum, and that is one of the reasons why these disorders are very complex to diagnose and treat. The spectrum can happen from a devastating infantile oxalosis, where options for treatment is very, very minimal. And also patients can present with various symptoms like just failure to thrive and unrecognized or undiagnosed renal dysfunction, to recurrent stone formers, to imaging finding of nephrocalcinosis, or diagnosis exactly at the last stage of CKD or CKD5 or allograft recurrence. They can also present very mildly with just a history of single stone formation, especially in a child, and also asymptomatic or pre-symptomatic individuals can sometimes be diagnosed. Is there any variation in the type of hyperoxaluria and the type of clinical presentation that you get? There seems to be more severe forms are usually seen in patients with primary hyperoxaluria. They present invariably with recurrent urolithiasis, and they have extremely progressive nephrocalcinosis, and most of them and majority of them have ESRD in the first 2 to 3 decades of life, and it is almost the norm in patients definitely by the age of 40 to 50 years. But nevertheless, this is a much heterogeneous type of disease, especially PH1. Within the same genotype and within the same families, many people can present with different types of symptoms and have a varying course of disease. And it's neither based on the specific, so you cannot predict the clinical presentation based on the clinical on the specific genotype or even on the level of the enzyme activity. And all this is thought to be because of environmental or epigenetic factors, or there are multiple other factors in your mutation analysis like post-transcriptional and other things that are going to play a role in the how the disease progresses and how the disease behaves. A primary hyperoxaluria too is less heterogeneous in presentation. Most of them, it's a less severe form also than the primary hyperoxaluria type 1. Most patients, however, have severe recurrent urolithiasis leading to a gradual loss of kidney function over time. And the risk of CKD5 in these patients is approximately 20%. And they constitute about 10% of patients with primary hyperoxaluria, and many of them still can go undiagnosed because of the less severe clinical course. Primary hyperoxaluria type 3 seems to be the second most common type of primary hyperoxaluria. It's more and more recognized now. This type is very interesting in that the urolithiasis sort of starts very early in the first decade of life. But however, as the age progresses, the disease tends to be slightly silent. It becomes clinically silent, and not many reports. There are very sparse reports of 1 or 2 patients having ended up to end-stage kidney disease with this type of hyperoxaluria. But generally, it's believed that primary hyperoxaluria type 3 would not progress to CKD5, and most patients are just managed conservatively. The most dreadful clinical presentation, however, is the systemic oxalosis. The widespread oxalate deposition starts when oxalate production overwhelms the kidney excretion, and it can start as early as an eGFR of 30 to 45 ml per minute. It can present in, as I said, no organ is spared with oxalate deposits. It can affect major organs like the cardiac tissue, resulting in cardiomyopathy, heart blocks, and heart failure. Vascular deposition in the form of non-healing skin ulcers, also resulting in skin calcifications, and also sometimes causing major organ infarcts, have also been like strokes, have also been described. Retinal deposits and sometimes dental root resorption occurs with oxalate deposition in the root pockets. Bone seems to be the biggest organ that is affected universally in almost all patients, because bone is the largest repository of oxalate. The manifestations in bone can be divided into the bone structure and also in the hematological aspects of bone deposition, or the marrow deposition. So bone pain and pathological fractures are seen in most patients with advanced systemic oxalosis, or especially in those who have late diagnosis. And erythropoietin refractory anemia or transfusion-dependent anemia. And also sometimes patients can present to you with hypersplenism at the first go, with refractory or excessive oxalate deposition in the bone marrow, prohibiting all the cell lines in the marrow. Peripheral neuropathy and autonomic dysfunction resulting in refractory hypotension have also been described. So these are some pictures showing the extensive systemic oxalosis and their devastating complications. This shows non-healing skin ulcers, almost necrotic areas that you see in the thigh of this patient. And this picture shows some lytic lesions in the bone. There is so much bone damage and osteopathy that there can be lytic lesions and poor bone structure, and also resulting in fractures and bone pain. Retinal calcium oxalate deposits, rarely affecting visual disturbance, also can happen one systemic oxalosis, and it's quite a very good screening tool to identify systemic oxalate deposits in these patients. The diagnosis of hyperoxaluria, this disease being rare and being very heterogeneous in its presentation, you need a high index of suspicion to diagnose primary hyperoxaluria, and it should be suspected in any combination of clinical, radiological, or laboratory features. Any patient with recurrent nephrolithiasis, either confirmed by renal ultrasound or an X-ray or a computer tomography, showing multiple bilateral radio-opaque densities, having nephrocalcinosis, which can be either medullary, it can be corticomedullary, which is often seen in older children and adults, or diffuse nephrocalcinosis, which is often seen in infants. A child with a first kidney stone should be definitely evaluated for primary hyperoxaluria. Any infant with failure to thrive along with impaired kidney function. The presence of renal dysfunction or end-stage kidney disease at any age with history of renal stones or nephrocalcinosis. A stone composition of pure calcium oxalate monohydrate, especially pure or more than 95% of the stone showing calcium oxalate in its monohydrate form, or any oxalate crystals identified in a biological fluid or tissue. All of these situations warrant intense and focused investigation to rule out a diagnosis of hyperoxaluria. Often we start with stone analysis. As I said, many of these patients present with urological symptoms at the first go. So either after stone passage or a stone diagnosed and you attempt a urological intervention, you get a stone which could be sent for analysis. Calcium oxalate is a main stone component, and particularly its monohydrate form. If it's present, if it constitutes more than 95% of the stone, it should be considered a very pathognomonic of hyperoxaluria. People have shown that macroscopic and microscopic appearance of these calcium oxalate stones compared to calcium oxalate monohydrate stones of other causes of, say, an idiopathic cause could differ could be very different. So primary hyperoxaluria enzyme deficiency confers a specific architecture to these stones, hinting at a different pathogenic mechanism at play here. So these stones are usually pale compared to the stones, calcium oxalate monohydrate stones that are not from patients with primary hyperoxaluria. So these are darker, but for the stones from primary hyperoxaluria are very pale. And they also see that they are more porous and they are more rugged in appearance compared to the non-primary hyperoxaluria stones, which have a radiating sort of an inner core and an outer core and a well-defined architecture. So these things can give you a clue. So usually stone analysis is attempted, and you should ask for a spectroscopy, infrared spectroscopy, to identify the monohydrate form. So it is important that you request this test when you attempt a stone analysis. The second most informative and the most easily available tests are the 24-hour urine collection for various urinary metabolites. So you are going to deal with a child or an adult or an adolescent with a high stone load. So urine analysis should always be attempted for a 24-hour collection. And it is useful to do not only oxalate, but also look at the calcium, citrate, sodium and uric acid and the magnesium levels in all these samples. At least the basic oxalate, calcium and citrate should be attempted in all these patients. This 24-hour urine examination is especially important in patients who have a preserved renal function. So they are more likely to excrete more of urinary oxalate because they have a good GFR. The normal excretion in normal individuals is less than 0.5 millimoles per 1.73 meter square. And usually anything more than 0.5 you should raise a suspicion of hyperoxaluria. And in primary hyperoxaluria, especially the type 1, the levels of 24-hour urinary oxalate is usually beyond 1 millimoles. There's too much excretion of oxalate in the urine. Especially in infants, sometimes the 24-hour urinary collection might not be possible. And in certain other situations when it's not possible, one can attempt to spot urine oxalate creatinine ratio. There are age-based reference ranges available, but a low creatinine in many of these patients can falsely give a higher ratio and can false positively diagnose a hyperoxaluria in many of these patients. So repeat collections may be necessary, or a confirmation again with a 24-hour collection might be necessary to confirm the diagnosis. Urinary calcium creatinine ratios might be helpful. It's especially low or normal in patients with hyperoxaluria. Also, even though these stones are calcium oxalate, many of these patients do not have hypercalciuria. In fact, many of them are reported to have low calcium excretion or normal calcium excretion. The exception may be in primary hyperoxaluria type 3, where it's variable. Many reports of high calcium excretion has also been reported. It is also an important test to rule out an idiopathic calcium oxalate stone. Some patients might not have hyperoxaluria, but they might be just calcium oxalate stone formers. Many of them do have associated hypercalciuria, so they might form a good supportive diagnosis when you're looking at a patient with hyperoxaluria. So these are the different ranges of urine oxalate excretion based upon age. I've also given the urine glycolate and L-glyceric acid. So L-glyceric acid especially can be elevated in PH2 patients because that is the substrate that is going to be there when the enzyme is deficient. So, and glycolate is usually increased in many of these patients. So, because it's just a precursor metabolite of the glyoxylate. So you can have, these are supportive tests, although urine oxalate should be fine enough for you to do. And when these are in the confusion range, or you do not have definite answers with these tests, you might go ahead and do the other metabolites in the urine. There are also spot values for the glycerate and the glycolate creatinine ratios, which are available. The other useful test could be plasma oxalate levels, and this is only attempted and it's mostly attempted in patients who have already had significant renal damage and a low GFR. So when you have a low GFR, you're not going to excrete as much urinary oxalate in your urine. So a urine oxalate might falsely tell you that the urine oxalate is normal or it's less, and take you away from a diagnosis of primary hyperoxaluria when in fact the patient has primary hyperoxaluria. So when there is significant renal dysfunction, please do plasma oxalate levels as opposed to urinary oxalate level. And it also can reflect the systemic oxalate load. And very high increased plasma oxalate can give you a hint of already systemic oxalate deposition happening in that patient. Patients with normal renal function can also have sometimes elevated plasma oxalate level because of the supersaturation happening and kidney deposition happening, but this is usually not attempted in them. And in dialysis patients, even when you do not have primary hyperoxaluria, because you are excreting anyway very little of endogenous oxalate production, normal endogenous oxalate production, you might have a slightly higher plasma oxalate levels. But this should not be confused for patients with primary hyperoxaluria. So patients with primary hyperoxaluria and end-stage renal disease have multiple fold increase in their plasma oxalate levels, usually beyond 60 to 80 micromoles per liter. Compared to patients with CKD5 due to other renal causes, where they might have only mild elevation of the plasma oxalate level. Plasma levels again of the other metabolites like glycolate and glyceric acid can also be done. This could be a chance diagnosis that some of us might step on when you're evaluating a patient with a kidney biopsy for some other reason. Kidney biopsy tissue can also show oxalate deposition. It is shown by polarized microscopy, which shows bright effringent crystal deposition. It is shown here. So usually the situations that we come across are when you do an allograft biopsy and you have a surprise on the biopsy. You do it for renal dysfunction of an unknown cause, and then you do not know the basic disease, and the allograft biopsy shows this, you know that the primary disease could have been primary hyperoxaluria. And also when you do attempt a native kidney biopsy for unknown etiology for renal dysfunction, you might end up having oxalate deposits and then go on to diagnose a patient with primary hyperoxaluria. However, more and more we are leaning towards genetic diagnosis for this disease. Genetic tests becoming more affordable and being more reachable and this thing for more patients, we definitely attempt to do a genetic diagnosis in almost all patients. And PH1 mutations, as I previously discussed, are more well characterized than the other two genes, the mutations or the variants. In PH1, there are 4 common pathogenic variants which are reported, of which 65% of them fall between any of these 4. The first mutation, most of these variants have a missense mutation, and missense mutations make up approximately 67% of any of these variants. So deletions and other frame shift and nonsense deletions are all very little. So most of them have missense variants. And you can order any of these tests. You can either do a single gene testing with sequence analysis and variant testing, or a multi-gene panel, or an extensive exome or genome testing. An extensive exome or a genome testing is more and more favored these days because it can rule out other differential causes of recurrent urolithiasis or nephrocalcinosis. So when you're not very sure of primary hyperoxaluria diagnosis, do include an extensive gene panel or an extensive exome or genome testing so that you include all the stone-forming genes into your panel. So there's a glycine and argine missense mutation. It's one of the most common variants that is seen in the PH1. This gene confers it slows the rate of dimerization of the AGT monomers. So it decreases the stability of the enzyme, and it also exposes the mitochondrial target. So it targets the protein fault state for the mitochondria. So these monomers are imported into the mitochondria rather than the perioxysome. And pyridoxine, which is used in some of these patients, is also likely attributable, and it's useful in these mutations because in part it enhances the dimerization of the AGT enzyme. And that's why in some of these genotype variants, pyridoxine seems to be useful. The other variant that in which has B6 responsiveness has been elaborately studied is the proline-losing variant. It is a minor allele phenotype, so that also confers some level of B6 responsiveness. 30% of these patients have a major haplotype variant, which results in a frame shift that has a nonsense mutation. So it results in very little enzyme level and early decay of the enzyme, compared to the missense mutations and the other three variants, which cause a mislocalization of the enzyme to the mitochondria. The last mutation sort of decreases the enzyme activity completely. There is no mislocalization or mistargeting here. Rather, the enzyme level itself is significantly reduced because of the mutation. These patients do not respond to pyridoxine. And although there is some genotype-phenotype correlation, especially to pyridoxine responsiveness, much is not known about other variants, and it's advised that all patients receive a course of pyridoxine to check for pyridoxine responsiveness. The other tests that could be used to diagnose primary hyperoxaluria, one is the previous gold standard method of doing a liver biopsy and establishing the enzyme activity of the AGT in primary hyperoxaluria 1. It is now reserved, very rarely done when you're pushed for a diagnosis in a patient, especially prior to transplant, where the clinical, the plasma oxalate or the urinary oxalate levels are not conclusive, and you do not have any help from the genetic tests also. One can go and attempt a liver biopsy and enzyme activity. And also, again, in a live related donor evaluation, sometimes you might attempt to look at because the patient's relative could be a carrier, could be a heterozygous carrier, so in whom you might be interested in knowing the enzyme activity before volunteering that donor for donation. So what are the differential diagnoses, and what could be the differential diagnosis for this condition? Once you have hyperoxaluria, or you have an increased urinary excretion or an increased plasma oxalate level, many of these conditions, or a calcium oxalate stone, the first three conditions could definitely be in your differentials, and one needs to take a careful history to rule out all of these conditions. So enteric hyperoxaluria is a condition that has, the problem is basically in the small bowel. There is fat malabsorption, and there is decreased oxalate reabsorption. Increased oxalate reabsorption and decreased excretion through the gut. So this can happen in various disorders like celiac disease, chronic pancreatitis, or any disorder that could cause a short bowel syndrome, any surgeries that could cause a short bowel syndrome. Dietary hyperoxaluria could be a major thing to rule out, especially in this a situation of people going in for smoothies and juices and salads and all that. Sometimes patients could be inadvertently taking too heavy doses of oxalate in their diet, especially lots of choco, cocoa, and leafy greens, nuts and peanut butter, and especially star fruit, which is notorious for its oxalate levels. Could also be one of the causes. So make sure that you rule out all these causes, or ask in the history for all these causes before you end up evaluating a patient for oxaluria. Idiopathic calcium oxalate urolithiasis can sometimes confuse and complicate a diagnosis, evaluation of primary hyperoxaluria. With certain features that would often differentiate this condition is that these patients have lower urinary oxalate excretion compared to primary hyperoxaluria. They tend to have less severe stone disease, and they rarely have renal dysfunction, especially progressing to CKD5. And there is a tendency to hypercalciuria as opposed to hypocalciuria in primary hyperoxaluria. The other very interesting differential diagnosis would be dense disease, because a lot of features do overlap between a primary hyperoxaluria patient and a patient with dense disease. You can have nephrocalcinosis, urolithiasis, renal failure, but however, the X-linked inheritance pattern and hypercalciuria and a genetic diagnosis, a mutation in CLCN5, could take you away from a diagnosis of primary hyperoxaluria. So the treatment strategies are complex. They are usually not very efficient, and especially the dialysis strategy. And the treatment goals are based on GFR at presentation. So a patient with preserved GFR or early CKD is managed very differently from a patient with advanced acidemia. Your goal for treating a patient with preserved GFR is in reducing the oxalate load and preserving the GFR as much as possible. Whereas in advanced acidemia, it is more likely to prevent and reduce the systemic oxalosis and other complications of systemic oxalosis. So in a patient with preserved GFR, you follow the fluid hydration, which would dilute the oxalate supersaturation. Roughly 2 to 3 liters per square meter body surface area is what is recommended. And crystallization inhibitors like oral potassium citrate or orthophosphate is used to alkalinize urine, with the ideal pH being suggested to be between 6.2 to 6.8. In patients with preserved GFR, they need routine monitoring to either to diagnose the GFR progression and also to early identification of systemic oxalosis. So they might need a kidney ultrasound, periodic urine analysis, frequent renal function tests, and also an eye examination, which could be an early sign of systemic oxalate deposits happening.
Dr. Sukanya, sorry to disturb. You have 5 more minutes.
Yeah, sure. So CKD or patients with CKD5 need to be screened very differently. The more focus is on the systemic oxalosis and to examine the multisystemic consequence of oxalosis. So determination of bone density, looking for cardiac deposits of oxalate, evaluating through ECG and echocardiogram, bone x-rays, and sometimes even a bone biopsy could be done to rule out osteopathy, and thyroid function test because of deposition in the glands could be done. And majority of these patients, the crux of the management prior to transplant remains initiation and maintenance on dialysis. Regardless of the GFR, all these patients should be advised to avoid dehydration from any cause which could lead to irreversible kidney failure, and avoid an intake of vitamin C that exceeds the RDA, which can promote oxalosis. Loop diuretics, NSAIDs, and other nephrotoxic agents, and large intake of foods high in oxalate should be avoided in all these patients. The other conservative treatment strategy would be pyridoxine. I've already discussed about pyridoxine's role and how it helps. So pyridoxine responsiveness should be tested in almost all patients, regardless of genetic testing and the variant that you get. Start at a dose of 5 mg per kg, and you can go up to a maximum of 20 mg per kg. There are no side effects, and a minimum trial period of 3 months is described. And a responsiveness is described as at least a 30% reduction in the urine oxalate levels from initiation of treatment. So you can discontinue pyridoxine if there's no response in 3 months duration. Probiotics are often discussed as one of the for decreasing intestinal oxalate excretion, but it seems to be very little and doing very little for these patients with extra and super heavy loads of oxalate in their blood. So dialysis remains a main strategy, but most patients have been starting dialysis younger compared to the previous year. So we do have this trend of starting dialysis early in these patients. But however, despite that, these patients have poorer survival of compared to other kidney diseases. Conventional the reason for this is that conventional hemodialysis and peritoneal dialysis are often poor removal, confer poor removal of the oxalate, and they do not remove. They are not good sources to remove oxalate at all. So you need more intensive strategies to clear the plasma oxalate level. So the strategies in dialysis could include short daily sessions of high flux dialysis. So use a high flux dialyzer, nocturnal dialysis, often 5 to 6 days in a week. A combination of hemodialysis and nocturnal peritoneal dialysis can also be attempted because often plasma levels rebound after hemodialysis session. The goal should be to keep the pre-dialysis levels of plasma oxalate to below to 30 to 45 micromoles per liter. Transplant, however, remains the mainstay of treatment and should be offered to almost all patients with this condition. As liver is the sole organ responsible for this glyoxylate, unless you change the liver, this disease is not going to get better. So excessive production is going to continue as long as the liver is there. So preemptive liver transplant prior to onset of kidney dysfunction has been variously described, but however, the ethics of doing a kidney or liver transplant and doing it in a child and putting them on lifelong immunosuppression is being questioned. Most centers do a liver and combined kidney transplant. It could either be done simultaneously or it could be done sequentially. There are many advantages of doing it sequentially because you have a liver which is reducing the oxalate load. Systemic oxalosis comes down by the time you keep an allograft in them. Combined liver kidney has also been attempted and is done, especially in the deceased donor setting. The donor could be either a living or the deceased donor, and you can also have a same donor, the liver and kidney, from the same deceased donor or from a living donor or from different donors. So various strategies are being used. The numbers are very little to discuss what's the benefit over one over the other. Kidney transplant alone can be tried in primary hyperoxaluria. As I previously discussed, the enzyme is ubiquitous. Liver cell transplant has sparingly been tried in patients, especially in infantile oxalosis, where none of these dialysis or dialysis being ineffective, none of these multi-organ transplants are viable in these patients. Liver cell transplant is attempted in some centers. Also, after transplant, you might have to continue hemodialysis or hemofiltration in many of these patients to reduce the systemic oxalate load, and that to prevent the oxalate deposits in the allograft. Urinary oxalate excretion may remain elevated for many years, and for this reason, many of these patients might be should have increased fluid intake and also use of crystallization inhibitors. The future therapeutic strategies, however, is promising for this condition, with something called the substrate reduction therapy being advocated and being tested in the recent years. So substrate reduction therapy, especially the drug lumasiran or Oxilmo, is being studied in many phase 3 trials now, and is shown to effectively reduce urinary oxalate reduction and also systemic oxalate load. There are also other methodologies and strategies being tried and tested, but I'm going to keep it short only about the lumasiran because of a shortage of time. So this is an ideal substrate reduction therapy target, because an ideal substrate reduction therapy should actually be a key step in the oxalate metabolic pathway and should inhibit the target, and the off target and the effects of such therapy should have minimal side effects. So this enzymes of glycolate oxidase and LDH are good targets for such a substrate reduction therapy. So what does lumasiran do? So lumasiran is an mRNA, is a liver-directed RNA therapeutic target of mRNA of glycolate oxidase. So this, when done, it takes over the function of glycolate oxidase and reduces the oxalate production down the stream of that oxalate metabolism. So it is administered subcutaneously at a dose of 3 to 6 milligram per kg per dose. There are also weight-based schedules that's being used in various trials. It can be administered once monthly for 3 doses, and then a maintenance of once every 3 months is what is predominantly used in these trials. And injection site reaction remains the most difficult side effect with this drug. So there are a lot of trials going on. This is the first trial which compared healthy participants and patients with primary hyperoxaluria, and administration of this agent increased the plasma glycolate concentration, which is the agreed and which is the expected effect of this drug. So the previous metabolite is increased, so there's no increased oxalate in the blood, and it also reduces the 24 urinary oxalate reduction both in healthy volunteers and patients. And also in the Illuminate A, which looked at patients who are more than 6 years old and have a GFR of more than 30, definitely compared to placebo, lumasiran decreased the oxalate 24-hour urinary oxalate reduction. The Illuminate B is based on, it's an open label trial, which included infants and young children with a preserved GFR, and also similar results were seen in this trial. The Illuminate C is a single-arm open-label trial which looks at patients with severe renal impairment of all ages, and patients who are hemodialysis dependent are also being enrolled in this trial. So I'll leave you with this. So we have discussed various strategies, the devastating complications of this disease. So this is a rare yet devastating disease and often results in end-stage renal disease. The diagnosis itself is very complex and is often missed in our clinical and in various clinical scenarios. And effective treatment strategies are only now evolving. Preserving GFR and preventing or decreasing systemic oxalosis remain the mainstay or the main goals of therapy. Intensive dialysis, offering multi-organ transplant to these patients, especially primary hyperoxaluria 1, should be done in all these patients, and substrate reduction therapies remain best future treatments to look forward to. Thank you.
Thank you, Dr. Sukanya. Thank you so much for this detailed overview of the hyperoxaluria. And this explains what the genetic variation is basically, which leads us to the clinical heterogeneity of the disease. But good to have the newer substrate inhibitors with us. So we'll be taking the questions at the end. And thank you so much for your time you gave to us. Now we'll proceed on to our second speaker, Professor Dr. Edwin Fernando. Sir is Head of Department of Nephrology and Transplantation at the Stanley Medical College and is a Senior Consultant. Sir is Senior Consultant at Dr. Mehta's Group of Hospital. Dr. Fernando has special interest in the living and cadaveric renal transplantation. And as is rightly said, that the nephrologist's job is never completed even post-transplant, particularly the fine-tuning of the metabolic abnormalities. So Dr. Fernando will highlight on the electrolyte imbalance in the renal transplant recipients, the post-renal transplant patients. So Dr. Fernando, the mic is yours. You can continue.
Can you see my slides?
Yes, sir.
Slides are visible. Yes.
Yeah, right. So thank you, Dr. Kalivani, and greetings to the chairperson from Karachi. And good evening all. Thank you very much for the opportunity to speak to all of you in this forum today. And as the chairperson rightly mentioned, this is an area that's not being paid much attention to because we don't have time to really look into this. As long as somebody's graft function is normal and he doesn't have fever and doesn't have any other infection or other complications, we are quite happy. But this is something that's silently going on in even stable renal transplant recipients. So I bring to you warm greetings from the Government Stanley Medical College, which is the 200-year-old hospital and an 80-year-old medical college. So this is a study of 76 renal transplant recipients whose electrolyte imbalance in the first 72 hours. This is a pediatric cohort. So you find hyponatremia nearly about 59%, hyperkalemia about 30%, and acidosis in 57%. So I shall concentrate on these three aspects alone. This is another cohort of 576 patients in whom post-transplant electrolyte imbalances were studied. And what you see here is the number of patients and the different electrolyte and mineral disturbances that can happen, starting from hypomagnesemia to hypokalemia. And these charts indicate that there are 2 electrolyte or even 3 and 4 electrolyte and mineral metabolism disorders in these transplant recipients. So what we shall be covering in the next half an hour or so is metabolic disorders post-transplant, disorders of sodium, and then disorders of potassium. So we'll talk about metabolic acidosis first. As I mentioned, that our attention is focused on immunological, cardiovascular, infectious, and other relevant clinical complications in the transplant setting. And this routine assessment of this metabolic complication is not routinely done, and there's also no major reference to this in the KDIGO guidelines in the care of transplant patients. It is a neglected area, but of potential clinical relevance. Chronic metabolic acidosis in CKD happens whenever there's a bicarb is low and the pH levels are low. There's a proportional decrease in PCO2. With a GFR of less than 30 mils, there's a 10-fold higher prevalence of chronic metabolic acidosis. And metabolic acidosis contributes to increased morbidity and mortality of CKD patients and to progression of renal disease. Chronic metabolic acidosis accelerates progression of kidney disease. So metabolic acidosis, a high dietary intake, leads to a single nephron ammoniogenesis that is increased. It activates the complement. This further worsens the tubular interstitial injury, the increased aldosterone contributing to glomerulosclerosis and decline in renal function. So what is the impact of this chronic metabolic acidosis? Is increased albumin catabolism, reduced insulin sensitivity, reduced oxygen delivery at tissue level, increased beta-2 globulin production, muscle wasting, reduced bone formation, increased bone resorption, growth retardation, especially in children, and in kidney function because of the ammonium-dependent complement activation, endothelin and aldosterone effects. It contributes to CKD progression. So this is the prevalence of chronic metabolic acidosis in different studies. And you see here that it ranges from something like 12% up to a high of about 60%. This is all cohort of post-transplant patients. So the reasons why there is such a wide variability is because of these different eras in which these studies were done, and what was the threshold that was used to diagnose metabolic acidosis. And the studies are not constant about the timing in which this was studied, and of course the difference in graft function. So again, here this is bicarbonate at the first month post-transplant, and this is a 12th month post-transplant. You find that the acidosis improves from 27% to about 16%. So what is the pathogenesis? These are mechanisms common to acidosis in CKD and mechanisms specific in the transplant setting. So in the CKD, there is a reduction in capacity of the diseased kidneys to eliminate the hydrogen ion load. So there is a reduced activity of both enzymes and carrier proteins responsible for the glutamine reabsorption, synthesis, and secretion of ammonia and bicarb transport. Why are relevant acid-base changes observed only when the GFR falls to the 20% of the normal values? This is because the compensatory mechanisms put in act by the residual renal nephrons, which can increase up to threefold their capacity of producing ammonia and eliminating the net acidity. In the transplant setting, there are different factors that operate. One is immunological factors, the effect of immunosuppressive drug, the donor characteristics, renal tubular acidosis, diet, and other factors. The donor factors, it has been observed that chronic metabolic acidosis is significantly higher in the diseased donor transplant recipients. This we have observed even in our institution. And metabolic acidosis is consistently higher in the period immediately following transplant, indirectly suggesting that there is a possible role of donor age, donor renal function, and cold ischemia duration of the occurrence of post-transplant chronic metabolic acidosis. Regarding the immunological factors, few case reports of early occurring hyperchloremic metabolic acidosis that may be associated with acute rejection. Sometimes it is antedating by 1 to 2 weeks, and the late occurring CMA associated with histological findings of chronic allograft injury. And immune-mediated injury could be involved with downregulation of the hydrogen ATPase pump and of the chloride bicarb exchanger in the distal tubule. So the plausible explanation of immune-mediated factors in the pathogenesis of RTA of kidney transplant recipients needs to be fully demonstrated. Regarding the role of immunosuppressive drugs, the commonly used drugs that are calcineurin inhibitors, mycophenolate, and steroids. With CNI, we have renal tubular acidosis that can happen in about 20% of patients. Both proximal and distal RTA have been reported. The RTA-inducing effects of CNI seem to be dose-dependent. Reduction of dosage reported to be often associated with the recovery of the RTA. Proximal RTA is characterized by bicarb wasting due to toxicity of CNI, and RTA is more frequent in patients on tacrolimus than on cyclosporine. And the RTA associated with CNI is often characterized by high potassium levels, a type 1B or a rate-limited RTA. The CNIs induce tubular dysfunction responsible for RTA. So the peptidyl proryl cis transisomerase activity is blocked. So this cyclosporine induces RTA by a specific cyclophilin-dependent mechanism, but not involving calcineurin inhibition. And tacrolimus can affect several major transport proteins in the renal control of acid-base balance, such as the hydrogen potassium ATPase pump and the anion exchanger 1. So this is how hydrogen is handled in the distal tubule. This is the type 1 intercalated cell where we have the chloride bicarb exchanger, the hydrogen potassium ATPase. And then in type B intercalated cell, you have the hydrogen potassium ATPase in the basolateral membrane and the pendrin that drives the chloride bicarb exchanger. And in the non-A, non-B intercalated cell, you have the pendrin-associated chloride bicarb and the hydrogen potassium ATPase. So these intercalated cells switch phenotypes mediated by a substance called hensin. There is increased activity of type A intercalated cell and increased activity of type B intercalated cells, depending upon whether the acidosis is metabolic or respiratory, or if it is alkalosis. So what is this hensin? Cyclosporin inhibits the polymerization of hensin. So normally, whenever there is metabolic acidosis, there is polymerization of hensin. This causes extracellular matrix deposition of hensin. And this makes a beta intercalated cell switch functions to an alpha intercalated cell. Now, cyclosporin inhibits this hensin. Other drugs like furosemide can cause type 1 RTA. High dose of vitamin D can cause a type 1 RTA. Trimethoprim sulfamethoxazole, again a type 1 RTA. ACE inhibitors and ARBs cause a type 4 RTA. An increased dietary acid load is associated with metabolic acidosis in transplant recipients. In the presence of subclinical tubular defects like incomplete RTA, an increased load of acids could make the metabolic disturbance overt. So in early post-transplant, there seems to be a predominance of type 2 RTA, while in late post-transplant, you have more of a type 1 RTA. So what are the types of RTA prevalent in the post-transplant setting? So this is given in this graph. The distal RTA seems to be more common than proximal RTA. So what is the impact of chronic metabolic acidosis in the transplant recipients? Not much news in the literature. Most of the studies are extrapolated from studies on CKD patients in various stages. But what seems to matter is the potential negative effect of chronic metabolic acidosis on bone demineralization in adults and worse height growth in transplant children. So these are areas of concern. So does it really matter that we identify and treat CMA in patients and kidney transplant recipients? Again, because there is paucity of data does not imply there is lack of clinical significance. Prevalence of RTA is consistently higher than that expected by the degree of graft function. It has got potential consequences on both patient and graft outcomes, and checking for and correcting metabolic acidosis is definitely easy and cheap. So how do you go about approaching these patients? A CMA with high serum anion gap. Look for general clinical conditions and drugs, withdraw them and adjust their doses. With a normal anion gap and hyperchloremic acidosis, if the potassium is more than 5.2, we'll have to check for drugs like ACE inhibitors, ARBs, and consider adjusting the dose and adding oral sodium bicarb. If there is a metabolic acidosis, normal anion gap, hyperchloremic acidosis, if the potassium is normal or low, look for GI causes, look for drugs, and then consider withdrawal, a reduction of the dosage, and add potassium or magnesium citrate. If none of the above drugs are implicated, check for the levels of CNI. If high, reduce the dose of CNI. Consider shifting TAC to cyclosporin, add oral soda bicarb or potassium magnesium citrate. If it is normal or low, consider acute or chronic rejection, probably helps you to decide on a biopsy. Add oral sodium bicarb or potassium magnesium citrate. So this is the mechanisms involved in renal acid excretion and consecutive systemic metabolic acidosis. We have a single kidney, there's definitely a reduced nephron mass. There is impaired renal acid excretion. A transplant kidney cannot give a GFR like that of a normal kidney. And there is general tubular damage, there's acidosis, impaired ammoniogenesis, impaired distal hydrogen ion secretion. There is decrease in the hensin polymerization, the use of calcineurin inhibitors. All this contribute to the metabolic acidosis. So when we were discussing this, we thought we should look at our data about metabolic acidosis. We have an active live related and disease donor program. This is a publication made by our team at the Stanley Medical College. We published this in the Indian Journal of Nephrology in 2019, where we found there was a significant effect, prevalence of distal RTA, even with adequate graft function. And screening for these on a regular basis is a feasible and cost-effective approach for early diagnosis. So the significant association that we found in our study was previous acute rejection episodes, current serum tacrolimus trough levels, cotrimoxazole intake, and animal protein intake were associated with acidosis. So with this, I move to the sodium post-transplant. Post-transplant polyuria. This is something that we commonly see. So this could be aquaresis or solute diuresis. Aquaresis is excessive free water intake. Hypotonic fluid infusion. Of course, we are all, as nephrologists, we are very careful with this. Transient NDI from NDI is nephrogenic diabetes insipidus from suboptimal tubular function. And unmasking of a CDI with a functioning transplant. Or it could be a solute diuresis where there is prior urea and uremic metabolite accumulation, natriuresis from saline infusions, and suboptimal immediate transplant tubular reabsorptive functions. And whenever there is a neurological disorder in the early post-transplant period, one has to definitely consider hyponatremia. Of course, we do consider hypertensive encephalopathy, press, CVAs, infections, etc. So, especially in the pediatric age group, the dangers of hyponatremia post-renal transplant are too evident. Hyponatremic encephalopathy can happen in children at an average sodium of about 120 with cerebral edema and death. Meticulous postoperative fluid management, especially in the pediatric kidney transplant recipients, is exceptionally important to minimize the risk of adverse neurological complications. Measures to avoid hyponatremia, of course, to use the crystalloid. This is the first choice for volume restoration. Half normal saline for urine replacement. Then monitor the serum sodium every 4 hours. And dialysis is performed the day prior to a preemptive transplant to minimize the precipitous drop in osmolality that can occur post-transplant. Coming to potassium post-transplant, the causes of hyperkalemia, calcineurin inhibitors, ACE inhibitors, ARBs, beta blockers, potassium-containing phosphate supplements, and underlying metabolic acidosis. So this is how the potassium is handled in the distal tubule. You're all aware about this potassium channel here at the luminal side and the 3-sodium 2-potassium ATPase. And of course, you have the aldosterone receptor that is situated inside the cell. Now, how does calcineurin inhibitor induce hyperkalemia? Inhibition of luminal potassium channel, reduce activity of the sodium-potassium channel in the basolateral membrane, and increase chloride reabsorption that prevents generation of a lumen negative potential. All this contribute to hyperkalemia. Now, one has to also keep in mind pseudo-hypoaldosteronism. Hyperkalemia and metabolic acidosis following cyclosporin in transplant may be associated with the downregulation of the mineralocorticoid receptor expression of the peripheral leukocytes. And there is interaction between immunophilin and the mineralocorticoid receptor that leads to impairment of the MR signaling pathway and could lead to pseudoaldosteronism. What is the role of fludrocortisone in this group of patients? It causes a significant decrease in the potassium within 48 hours. The dose ranges from 0.1 to 0.4 milligram per day. Duration may be up to 14 days of therapy. Causes of hypokalemia post-transplant, dietary potassium restriction, overzealous use of diuretics, underlying hypomagnesemia may potentiate hypokalemia, and the mTOR inhibitor, sirolimus, is known to produce hypokalemia. But more than this, it is the intense diuresis that happens post-transplant that contributes to hypokalemia. So I would conclude here by saying electrolyte disturbances in the renal transplant recipients are common and may have significant effects on both short-term and long-term outcomes, including cardiovascular disease and post-transplant bone disease. So I stop here and I'll be happy to take a few questions.
Thank you, Dr. Fernando. Thank you so much for an overview regarding particularly the acidosis, tubular acidosis, post-transplant and its various etiologies. So we'll proceed on to the Q&A and we'll see the questions related to Dr. Sukanya and sir. So the first question was where to get the plasma oxalate level in India. That Dr. Sukanya can respond.
Plasma oxalate level is definitely done in India, and we do routinely that in evaluation of a donor, and sometimes as a part of a live related transplant, sometimes to just rule out hyperoxaluria in the donor or something like that. And also in patients with, as I said, preserved GFR plasma oxalate, it is available. I can pass on, the question is asked by Dr. Anshuman Saha, so I can pass on the labs that they would do. Labs like Lalpath, very widely available, they do plasma oxalate levels. Also, these levels are quite often used in patients who have undergone a transplant, a successful, say, a combined liver kidney or a isolated liver, to check how efficient the transplant is working, especially the liver transplant, in looking at the plasma oxalate levels. So sometimes we monitor the serial levels. We do, say, every 15 days, depending on the unit protocol. So it's definitely part of your management, and it's definitely available in India. Most standard labs and very good labs which have branches across, and major labs do it. I will pass on the details to Dr. Saha. If he needs it, I will contact him. Yeah, thank you.
Thank you. Thank you, Dr. Sukanya.
Can I add to that, madam?
Yes, yes, sir.
If you're trying to diagnose primary hyperoxaluria by looking at oxalate levels, most patients come in quite late. So as the GFR reduces, the oxalate levels also tend to reduce. So sometimes if you're going to use it for diagnosis of a CKD patient with oxalosis based on plasma oxalate, may not really work out. And of course, we now have better methods of diagnosis.
Okay. Thank you. Thank you so much. So the other question I think was already responded in Dr. Govindan's presentation, that yes, we have the urinary levels to detect other substrates like glycolic acidurias. So that answers the questions of our colleague. The other question is regarding, should pyridoxine be continued when on dialysis, and what is the adequate dose when on dialysis, and could it be administered IV post hemodialysis? So 2 and 3 queries.
Yeah, right. So should pyridoxine be continued while on dialysis? Yes. So pyridoxine is an effective strategy in patients who are responsive to reduce the systemic oxalate load also. As I said, the pyridoxine makes the enzyme accelerates the enzyme dimerization. It increases activity, it increases the stability. So regardless of the GFR status or whether you're on dialysis, pyridoxine would act in such patients also. It would reduce the systemic oxalate load if such patient is going to be responsive. So being on dialysis should not make you hesitant to start pyridoxine in your patient. I would not think that there is a different dose for patients on dialysis, because there is a water-soluble vitamin and does not accumulate in your body when you're on dialysis. So there is no specific dose or anything that you would change for a patient on dialysis. But the general guidance is to start at a particular dose and increase till you have your effect. The only problem with starting pyridoxine and monitoring a patient while on pyridoxine, while on dialysis, would be you're not going to go by your urinary oxalate level. So how would you actually try and assess the responsiveness? So that is more a question rather than whether pyridoxine could be used. So for me, if I were to see a patient in the end stage and he or she is already on dialysis, and whereas I do not have the genetics to assist me to look at the pyridoxine responsiveness, definitely give a trial of pyridoxine. I don't think there would be any harm in giving pyridoxine to them. Although I would quickly take them on to transplant to look at other better options for them, but definitely try pyridoxine in the meanwhile. There's no contraindication to start that in a patient with that.
Thank you. Thank you.
And IV pyridoxine, being a water-soluble vitamin, could be removed during dialysis, and giving it as a oral dose or an IV dose wouldn't matter, but I think it should be given post-dialysis on dialysis days at least. That could probably increase the effect of the medicine more.
Yes. And since there is no severe harm, so it's better, as you have suggested, to be continued on dialysis patients even. Thank you so much. And
the dose is definitely much higher than what you would normally prescribe. So it is not the we do give pyridoxine when we give INH, etc. But the dose should definitely be a much higher dose.
Yes.
If it is intended for the purpose that we are giving. especially in patients with hyperoxaluria. The other comment, with your permission, ma'am,
Yes.
is patients with primary hyperpara can be mistaken for oxalosis. Of course, now we have genetic diagnosis, but somebody has bilateral stones, has developed renal failure. They can have, I've seen a couple of patients in whom oxalosis was missed and parathyroidectomy was done thinking it was a primary hyperparathyroidism.
Oh.
So this has to be kept in mind.
So this is very important, where our urinary and the serum substrate levels are very important to differentiate among this very important differential diagnosis. You are very right, sir. Thank you. Thank you for your response, sir. And the last is question in the QA box is again for Dr. Govindan. A child with medullary nephrocalcinosis presents with end-stage renal disease. Genetic analysis and plasma oxalate level is inconclusive. There is family history of sibling death with renal stones in the first decade. Parents are keen on transplant. How to proceed? Should combined liver and kidney transplant be offered in this case, ma'am?
Yeah, so quite a challenging question. It's been asked by my own fellow, so I think as challenging as a student could challenge a teacher. So there are a couple of things in this. So this patient definitely has a setting and has to be extensively evaluated to rule out a primary hyperoxaluria, especially in the context of attempting a kidney or a combined liver and kidney transplant in this patient. So the genetic analysis and plasma oxalate levels remaining inconclusive, I think we should at least attempt to completely look for evidence of systemic oxalosis in such patients. The patient being end stage and is probably not been, no other forms of treatment being available. There must be every attempt made to look at systemic oxalosis if possible. And the other option is looking at the enzyme level activity, at least for primary hyperoxaluria type 1. That is definitely attempted in certain centers like multi-organ transplant centers, at least in our part of the country. This level activity is also used to see whether sometimes when the diagnosis influences. So these are two things that one could attempt and try and find if it helps your diagnosis or refutes your diagnosis of primary hyperoxaluria. That also being very inconclusive, often we do come across patients or patients do not have the financial resources to go on keeping evaluated. I think it's a very, very cautious and a very team discussion both with the parents and the family before attempting an isolated kidney transplant. I would not upfront, without a diagnosis of primary hyperoxaluria, go and suggest a very complex surgery like a liver and kidney transplant to anybody without a diagnosis. That definitely would not be offered unless we have a proven diagnosis of primary hyperoxaluria. Again, while attempting an isolated kidney transplant, every due diligence should be given to the health of the allograft, to the possible consequences of a misdiagnosis of primary hyperoxaluria, both to the parents, to the patient. Everybody in the team should be alert to such a possibility. And it would be very grave if this thing should be done. And one thing that can be offered is a deceased donor transplant rather than attempting a live related transplant in such patients. Often in India, many patients go on to receive a live kidney from a related donor. So if you're pushed to do transplant in a patient without a diagnosis and primary hyperoxaluria still not being ruled out conclusively, at least a deceased donor transplant. So this is how one should be approaching this patient.
Thank you.
The other thing is when you look for systemic oxalosis, simple things that we can do is do a bone marrow biopsy. Bone marrow where the oxalate can get deposited. Other thing that we can do is ask a vascular surgeon to take a biopsy from the vessel wall while doing AV fistula. And diligent fundus examination, optic fundi examination also can show deposition of oxalate, especially when the oxalate load is very high. We have seen a couple of patients who had oxalate deposits in the retina. And very recently, where a patient could not afford a genetic testing, we had a biopsy done from the radial artery, and that showed extensive oxalate deposits. So that should at least, not to confirm a diagnosis, but at least it's oxalosis and you would not venture out into a kidney alone transplant, but look at a liver kidney transplant.
Thank you. Thank you so much for your precious comments and detailed comments on the questions. And very rightly considering it as a systemic entity, so we have opportunities from the number of places to detect the oxalate deposits. My query regarding this oxalosis, if we have initial presentation with the stone before patient become dialysis dependent or end stage with the evidence of oxalosis, so can we embark on the liver transplant earlier? Your comments, Dr. Fernando or Dr.
The earlier, the consensus was to do a combined liver kidney transplant.
Okay.
If it is a proven oxalosis. Now people talk about sequential liver kidney transplant. That is, you do a liver transplant, allow all the oxalate to be metabolized and then get deposited on the kidney, and then plan a kidney transplant. So this is what people think about it right now. Anyway, Sukanya has read more extensively. She'll be able to tell us.
To go for hepatic earlier and then look for the renal status.
Sequential transplant.
Thank you so much.
Isolate liver transplant or a preemptive liver transplant, exactly what you asked, has many issues inherent with it. Although in a patient with preserved GFR, one might think that it's a preemptive liver transplant would take away the faulty liver and reduce the oxalate load and prevent the kidneys from getting
going to the.
Often we see there are a lot of ethical issues in it. If the child is going to be young, how preemptive is good? How preemptive is going to be, there's already some amount of chronic kidney disease that has been set in with excessive oxalate deposition. And they might continue for quite a while, even after a preemptive liver transplant. The ethics of giving lifelong immunosuppression and giving immunosuppression at such a young age when the otherwise with a functional liver and a functional kidney is also being debated. The only advantage, or at least on paper, for doing a preemptive liver might be compared to a more morbid surgery of a combined liver kidney or a combined or a sequential liver and kidney. You get one organ transplant, liver being less antigenic, less prone for rejection. The immunosuppressive doses or the cumulative immunosuppression when you embark on a combined or a multi-organ transplant might be very little. Evidence against or for is still evolving. Very few centers do preemptive liver transplants. But what is needed is a combined decision and discussing all the pros and cons with the family, with the team, and knowing what you're pushing the patient into and what are your goals at the start of initiating such a transplant. Taking such a decision is very important.
So everything has its plus and minuses. You have to monitor them closely. So in our panelists, we have Sir Dr. Namalwar also with us. So I'd like to take Sir's opinion and comments regarding both our topics of discussion today. So you are with us?
I'm there.
Yes, sir. You are audible. Sir.
But it is very difficult for me to speak something more than what Dr. Mrs. Govindan and Dr. Edwin has spoken. Both have been professorial talks. I learned a lot, particularly the aspect of metabolic disorders in transplant. We are so concerned with rejection, infection, and drug aggression, we tend to forget. And we leave it to a junior youngsters to manage those problems. I think it's been a terrific eye-opener for me. And of course, Dr. Sukanya Govindan has been always perfect, and today is more perfect. Thank you, both of you, ma'am.
Thank you, sir. Thank you, sir, for your feedback and your comments. So we'll check last time the Q&A. I think we are done. Liver biopsy was asked, so we are already done that we can review all the organs in the body for oxalate deposits. So can I ask one question for Dr. Fernando? So we discussed regarding the CNIs as the culprit for the renal tubular acidosis. So is there any certain level of the CNI levels or any certain duration post-transplant that we are getting this acidosis, the tubular disorder, CNI?
No, ma'am. All this is demonstrated at whatever stage of transplant. And though people have shown that higher levels are associated with this acidosis, there is no proven relationship in this, and there is positive literature on this also. CNI being a very, very important drug, especially in the first year post-transplant.
Yes, sir.
I don't think anybody would try to reduce the levels of CNI in order to prevent metabolic acidosis.
Yes.
Probably we would continue the CNI and treat the metabolic acidosis by whatever way we could. So there's no data to say that this particular level is associated with metabolic acidosis.
So in your
And,
practical experience, or even with the normal CNI levels, you are getting acidosis and managing accordingly.
Yes, because it is not only the CNI, it's very difficult to find out which is the cause, because
Exactly.
the GFR of the transplant kidney is already low. We are not getting a GFR of 90 ml. We are getting a much lesser GFR.
Yes.
This is one there, and there are a lot of areas that I actually did not cover for lack of time. One is hypomagnesemia, hypophosphatemia, the recovery of the mineral bone disease after transplant. This itself takes about a year to recover completely, provided there's a normal graft function. So these changes that are there in CKD take a long time to really recover. So some of these mineral bone disorders could actually persist for some time. And if the graft function is normal at the end of 1 year, probably there is a time when all these normalize. So it is just not sodium, potassium, and acidosis, but there are a lot of other things like
the
magnesium, phosphate, the post-transplant mineral bone disorder. These are big areas that are normally not looked into by the clinician, and these are areas of research.
Yes, the hypophosphatemias, dyslipidemias, sirolimus-induced dyslipidemias. So there is again a spectrum of post-transplant metabolic abnormalities. That was really an interesting topic for all of us. Dr. Calvini, would you like to give your feedback or any comments, questions?
The doyens are already spoken. Like, I don't think I have any comments to add. I think there is one question. There was a question on whether urinary levels of glycolic acid is detected in pH type 2.
Yes, that was already responded in Dr. Sukanya's presentation, that we can screen the urinary panel for the glycolics.
Okay.
So this was
these are not routinely available. They are most available in research laboratories. There's one oxalate center by Dr. Christopher Danpour somewhere in the UK. So in fact, a few years back, when I was a student, we tried to send some samples across, but the courier guys could not take these samples to UK. We had no other go. In fact, if you go down into history, other than doing a bone marrow biopsy and the arterial biopsies, we used to do kidney biopsies. And sometimes the kidney is small and you don't have any other way to prove or disprove oxalosis. So we used to do an open kidney biopsy, and we used to send it to Christian Medical College, Vellore, where they used to do a scoring system called the Scheinman scoring. So where they used to actually calculate the amount of oxalate in the tubules. Now, what happens is, even in end-stage renal disease of any cause, oxalate gets deposited in the tubules of the kidney. But that is only the score. There's a calculation for that has been published by the CMC group way back in 1994 in the journal called Nephron. So the Scheinman scoring was used. So we used to send this sample to pathology, Norman Institute of Pathology in CMC, Vellore, and they used to give us a score. So any score of more than 60 was suggestive of oxalosis. So if you're able to get a kidney biopsy, there's of course nothing like that where it shows extensive deposits of oxalate. But in today's world, I think nobody would, without genetic testing, I don't think we can actually. Most important thing is to recognize and then to plan for a combined transplant or a sequential transplant, because it's disaster. We have seen patients when I was working in the Government General Hospital, where patients would come with a calcified transplant kidney. The chest the X-ray of the if you take a KUB X-ray, you can see the entire kidney calcified because the diagnosis of oxalosis was missed. Of course, there was less awareness about the disease at that time. So somebody comes in with and stone is such a common problem in our country, in our part of the world. We live in a very hot tropical climate, and somebody has recurrent stones and then lands up with CKD. So unless you have knowledge about this oxalosis, one has to rule it out. And if there's a family history, a young person, bilateral stones, recurrent stones, stones associated with renal failure. So these are the areas that one needs to concentrate. I have seen a patient who had oxalate deposits in the Purkinje fibers of the heart, and the patient was coming with a recurrent heart block, and ultimately it turned out to have oxalosis.
So that this
I had a collection of 50 patients with oxalosis. It is very sad that I did not publish it, but these are different manifestations of the disease.
Great, interesting. And that is which takes us to the other end of the spectrum, where Sukanya told the genetics and how the severity of the genetic variation that gives us a different clinical manifestation. How severe is the genetic variation? Dr. Sukanya, had you had your genetics done in any of your patients of oxalosis? Any experience of yours, and what type of variation you are getting? Kindly unmute.
So we do attempt to do the genetic confirmation in all our patients. And we see most commonly, I would see, because the numbers that we do is very little, this being a rare disease, one might not be seeing enough patients to comment on what's the most common variant that we are seeing. But definitely in most of our patients, unless otherwise we have strong evidence or there is already a positive history in the family, we definitely attempt a genetic diagnosis. And more so in our part of the country, in our state, genetic diagnosis being now offered in government centers according to the insurance, and it's also being covered, most of it. So we do find ways and means to definitely get a genetic diagnosis. And because most of these patients would be planned for a multi-organ transplant vis-a-vis an isolated kidney transplant, and most of them do end up in the end stage to us in the last stage. So we do attempt a genetic diagnosis. There's no question of, just not doing a genetic diagnosis. Okay. So we do attempt, and all attempts should be made for a genetic diagnosis. I might not be able to answer which is the most common variant in our center or something, because the number of cases are quite little to comment on that.
Okay. Thank you so much. Thank you. So with this one last coming to the earlier spectrum of the oxalosis, have your experience of the enteric and the dietary, the enteric particularly the oxalosis?
So I've just had seen one patient who has had an AKI, he's a young adult of around 21, 22, who's underwent an extensive intestinal surgery and then had an AKI. So it was thought to be acute tubular necrosis, and it was just postponed. The biopsy was done because of non-recovery of kidney function, where we picked up oxalate crystals in his kidney. And so we assumed that this patient has enteric hyperoxaluria. So there was excellent recovery of kidney function after a while, after hydration and all that. I believe there could have been some residual damage, but definitely the kidney function, as evidenced by creatinine and his urine output, all became normal with aggressive hydration and also crystallization inhibitors like potassium citrate. So that is my very little experience with enteric hyperoxaluria.
And I think in that case, the serum oxalate are also not very drastic to really guide us to
I attempted the serum oxalate testing in him because his kidney function was recovering. So I would not have gotten anywhere with the serum oxalate level. It would not have helped me in the diagnosis or review.
Definitely. So thank you for your extensive discussion and your generous time to the IPNA and Dr. Calvinis and all of our team. So it was really interesting.
Sorry to interfere. There is one last question for Dr. Edwin Fernando.
So, sir, there is 3 months post-transplant persistent asymptomatic hyponatremia. Serum sodiums between 110 to 115 millimoles. How to manage? Any role of 3% saline administered orally? Is persistent hyponatremia a prognostic marker for the poor graft outcome? So it's considering hyponatremia.
Yeah, you can't be giving 3% saline orally. You'll have to find out why this has happened. many of our patients, even after they have received a transplant, continue to be on a very low salt diet and continue to be on a CKD diet instead of coming back to a normal diet. So this I found is the main reason why they generally tend to be very weak, and then they have low salt intake, and especially in a weather like ours, hotter and hottest. That is the weather that we have. So before embarking on treatment, go through a detailed history, look at the prescription, look at the drugs to see whether there could be any drugs that can cause hyponatremia, and try to sort out instead of giving 3% saline. The most important thing is to identify the cause rather than the treatment. And somebody who's got a chronic hyponatremia, there is no rule for giving 3% saline unless the patient is symptomatic. If he is asymptomatic, you must try to find out the cause, increase his salt intake, look at his prescription and try to avoid drugs that could produce this hyponatremia.
So good. Initially, we should try to evaluate the underlying cause of the hyponatremia.
That is most important. Correct.
And the symptom is how much is the symptomatic our patient. But oral 3% if needed, we can give. There is no harm in continuous or maintenance 3% oral.
But how long would you keep giving this? So unless you find out the cause.
Yes, definitely to evaluate the cause. Thank you for your response, sir. So I think now we are coming to the end of our session, and I'd like to thank both of our eminent speakers, Dr. Namalwar for being with us on board, Dr. Calvini for organizing and persistently continuing with the webinars, for the teaching and training of not only for the juniors, but also refreshers for all of the seniors. So I thank you all for your presence, and thank you and goodbye from my side. We'll stop the session here. Thank you all.
Thank you,
ma'am.
good night.
Thank you, ma'am. Good night.
Thank you.
Thank you, night.
Thank you, Doctor. Thank you, sir.
Thank you, Dr. Asim, for the excellent moderation.
It was my pleasure. We'll work together, inshallah.
Thank you for joining us from Karachi. Nice to have you.
Thank you, sir. Thank you.
Thank you, sir. Good night.
Thank you.
Thank you.